Welcome to the next installment of Morning Report Emergency Medicine. I'm Alec Weir. Let's go ahead and get started. This is the case of two left feet. A 45-year-old man without any significant past medical history is brought in by EMS complaining of an ankle injury. He was painting on top of a 10-foot ladder when he fell to the ground and had immediate pain and deformity of that right ankle. Has not been ambulatory since the accident. He is neurovascularly intact distally and has had no prior injuries or surgeries to this ankle. And you whisk him off to radiology, and this is what you get. Grossly abnormal, right? We have our oblique film here. We have our lateral, and rarely are you seeing all 5 metatarsals on a lateral film of the foot. And now back to our AP. What do we have here? What is this? This is a subtalar dislocation. It is not an ankle dislocation, okay? So in a subtalar dislocation, you have rupture of your talonavicular and your talocalcaneal ligaments, with usually preservation of your calcaneonavicular ligament. These usually happen medial or lateral, but you also can have anterior dislocations. Luckily, neurovascular damage is uncommon in subtalar dislocations, and greater than 80% of these can be treated with closed reduction, which means in the emergency department. So let's take a look at this picture. Why is this called a subtalar dislocation? Well, this is your talus, all right? So if it was an ankle dislocation, you would have a dislocation here, all right? You have a dislocation between your tibia, your fibula, and your talus, but you have a dislocation here, a subtalar dislocation. So let's reduce this thing. In the emergency department, it was done with moderate sedation under fluoroscopy. The key is knee flexion. All right, get that knee flexed at 90 degrees to relax the Achilles and to deactivate that gastrocsoleus complex. You want to use longitudinal traction on that foot in line with your tibia, initially exaggerating the injury, followed by reversal of that injury. And now there are some things that will make reduction impossible. Things like buttonholing of the talus through the extensor retinaculum, entrapment in the peroneal tendons, or certain associated fractures. Here we have our post-reduction fluoroscopy, looking much better, right? We see we've got our tibia here, we have our talus, and we have much better alignment here with our calcaneus and our navicular bone. So we have good reduction here. So what do we do post-reduction? Well, we need to immobilize. So that's done with a stirrup. So a U-shape piece of bracing that supports the medial and lateral aspects of the ankle, and then you can also add a posterior short leg if necessary. So what are our take-home points? Subtalar dislocation is not an ankle dislocation. They are different. This is occurring, obviously, distally to the talus. Fortunately, neurovascular compromise is uncommon in these injuries, but you do have to know how to reduce them because greater than 80% can be reduced in the emergency department. You want to keep that knee at 90 degrees of flexion to relax the Achilles. Pull the foot in line with the tibia, initially exaggerating the injury, followed by the reduction. Immobilize it with a stirrup splint and get some expedited orthopedic follow-up. All right, guys, that's it for this week. I want to thank one of my co-residents, Caleb Pierce, for this case. And as always, I appreciate the feedback and keep your eyes open for more interesting cases.